Rhonda Whiteman is our presenter today, and she is the Stroke Best Practices Clinical Nurse Specialist at Hamilton Health Sciences. She supports teams within Hamilton Health Sciences and the Central South Stroke Network to implement best practices for stroke care across the continuum. Rhonda completed her Master's of Nursing from the University of Toronto in 2008 and her Bachelor of Science in Nursing from McMaster University in 1989. She has maintained her Canadian Nurses Certification in Neuroscience Nursing since 1994. She holds a part-time assistant clinical professor in the School of Nursing, Faculty of Health Sciences at McMaster University in Hamilton, Ontario. She's a member of the RNAO Stroke Assessment Across the Continuum Best Practice Guideline Development and Regional and Review Panel. She has presented a number of papers at regional, provincial, and national conferences over her 35-year nursing career in neurosciences. Welcome, Rhonda.
Thank you, Tina. I'm going to share my screen. It's my pleasure today to really provide some overview of anterior stroke assessments. And my objectives for the session today are to review the clinical presentations of the common ischemic stroke syndromes, and we'll discuss some key assessments for patients with anterior circulation strokes, with a focus on stroke symptom onset, last known well, speech assessments, motor assessments, neglect, and a visual disturbance field deficit. So we'll start off with the case. Our first case is a 56-year-old female who was observed by her husband to collapse while eating dinner. When he went over to assist her, she could not speak, had right-sided facial droop, and could not move her right arm and leg. So let's do a bit of neuroanatomy review in some of the anterior stroke syndromes we're going to see. So if we think about cerebral circulation, the brain has high requirements for oxygen and glucose than any other organ. Approximately 20% of the resting cardiac output is supplied to the brain at the rate of 800 to 1,000 mLs of blood per minute. The brain derives its anterior supply from its arterial supply to a pair of carotid arteries, which supply the anterior circulation. So here are two internal carotid arteries and two vertebral arteries, which supply the posterior circulation. The anterior circulation is provided by the internal carotid and its branches, which supply the anterior 2/3 of the cerebral hemisphere. What you can see is that the internal carotid originates from the aorta and then gives rise to the tympanic and the ophthalmic arteries. After both of the internal carotids enter the brain, they branch off into the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery. Posterior circulation is supplied by the vertebral arteries and its branches. The vertebral and basilar arteries supply the posterior and medial regions of the hemispheres, the brainstem, diencephalon, cerebellum, and the cervical spinal cord. The vertebral arteries originate off the subclavian artery and enter the brain through the foramen magnum. The vertebral arteries unite at the base at the pons to become the basilar and then divide to the posterior cerebral arteries. Cerebral circulation is tightly regulated to meet the metabolic demands in healthy patients. However, the ability of the brain to autoregulate is lost if the brain is damaged. Decreased cerebral blood flow can lead to ischemia, infarction, and cerebral edema. So if we look at and think back to sort of our neuroanatomy, the brain is made up of three parts: the cerebral cortex, the brainstem, and the cerebellum. If we look at the cerebral cortex, as we know, it's made up of four lobes: the frontal, the parietal, the occipital, and temporal lobe. The frontal lobe is the largest, and it is composed of, makes up 60% of the cerebrum. It has three functional areas. The first is the prefrontal area. This is where it focuses on concentration, abstraction, memory, judgment, insight, emotions, tact, inhibition, sequencing thoughts appropriately, evaluating the consequences of actions, solving intellectual functions, guiding behavior in accordance with social laws and mores. As a mother of two teenage sons, I can assure you that prefrontal cortex is not fully developed until the age of 25. And so certainly can see some of the development as that's changed over the years. The other area of the brain is the Broca's speech area. This is where we have expressive speech, speech expression, word formation, articulation, pronunciation, voice, and speech production. The other key function of the frontal lobe is the motor cortex. It is arranged to somatic topically so that certain areas of the region control specific areas of the contralateral body. So as you can see here, the face, hands, arms, neck, trunk, hip, leg, toes, look up on the motor and sensory homunculus. When we look at the parietal lobe controls sensation on the opposite side of the body. The sensory cortex is also arranged in a topographical sequence to the motor strip. It controls the integration of sensory information among various modalities, including point discrimination, pressure, temperature, body integration, orientation, pain, proprioception, and visual spatial information in the non-dominant hemisphere. Major sensory inputs from the skin, so touch, temperature, pain receptors, relay through the thalamus to the parietal lobe. Injury to this part of the brain in the non-dominant hemisphere, which in most people is the right hemisphere, may result in neglect of a part of a body. Sometimes patients with an injury to this area are sitting on their arm. Their arm may have fallen off the wheelchair because they're unaware, or they may try and get up out of bed off the stretcher because they're unaware of their deficits. When we look at the temporal lobe, this is the primary auditory and associated areas. It also is the primary auditory area, which receives, discriminates sounds, and interprets sounds. It also, when we look at here, it's also where Wernicke's area is. And it is really what that area is it's a region between the temporal and parietal lobe, play a key role in tandem with Broca's area in speech comprehension, comprehension of language. The temporal lobe looks at integration of somatic, auditory, and visual association. It also is where we have detailed memory. If we look at the occipital lobe, it is primarily the vision center. So it's our primary visual, receptive, and associate areas of the brain, spatial organization of vision, sharp borders, colors, contrast, and visual interpretation. When we look at the brain stem, it is made up of the midbrains, pons, and medulla. The brainstem is an important role in regulation of our cardiac and respiratory function. It regulates the central nervous system and is pivotal in maintaining consciousness and regulating our sleep cycle. The brainstem also has basic functions, including heart rate, breathing, sleeping, and eating, and it houses all of the cranial nerves. It is responsible for transmission of information from the cerebral cortex to the brainstem and cerebellum. All of the sensory pathways pass through the brainstem. At the top of the midbrain is the reticular activating system. This is really where our arousal, our level of consciousness, our alertness. Patients who have difficulty or interfering in their reticular activating system have difficulty with their level of consciousness. Finally, we'll move to the cerebellum. It is really maintains the equilibrium, balance, coordinates the autonomic movement, and regulates muscle control. It receives sensory input from the spinal cord and brain and coordinates this into fine precision movements. Damage to the cerebellum produces disturbances in fine movement, equilibrium, posture, and motor learning. I often think about patients who have cerebellar dysfunction as those patients who, if you think about DWI testing, that if you've ever seen it on a television show, patients will have difficulty with walking a straight line, doing heel to shin. They may have an ataxic staggering gait. They can't perform finger to nose. They have sort of a very uh, stuttering or irregular finger pattern. What you can see on this pictorial is, again, you can really see where all of the key areas of the brain are. So the motor cortex, the sensory cortex, our Broca's speech area, our Wernicke's speech area, our hearing center, again, our vision center, where our balance and equilibrium is. So let's talk about some of the common stroke syndromes that we see in our patient. Certainly, middle cerebral artery strokes account for 2/3 of all of the ischemic strokes we see. Because the middle cerebral artery supplies the lateral aspects of the frontal, parietal, temporal, and occipital lobe, what you see is patients will have hemiplegia of the face, arm, and leg. They'll have sensory loss in the face, arm, and leg. They will have homonymous hemianopsia or loss of vision in one particular visual field. If it's on the left side, they'll have aphasia. So they may have expressive aphasia or receptive aphasia. They may also have apraxia, where they lose the ability to execute or carry out movements despite having the ability to perform. Also may have confusion. If it's on the right middle cerebral artery, they may have neglect, and they may also have headache. If we look at the anterior cerebral artery, the anterior cerebral artery strokes supply the superior and medial aspects of the parietal and midline with the shift. It's a less common type of stroke that we see, but if you think back to sort of our motor and sensory homunculus earlier, because it only supplies the medial aspects of the frontal and the parietal lobe, what we see is it's usually the leg where the patient experiences sensory or motor loss. So they have weakness of the lower leg. As a result of the weakness, they have impaired gait. They have sensory loss to the toes, the foot, the leg. Because of the prefrontal area that we see with anterior cerebral artery strokes, these patients may have very flat affect. They may have very emotional lability. They may have difficulty initiating activities. They may be quite apathetic. They may also have a lot of maybe quite impulsive. They may not be processing correctly. A lot of executive function. They may also have some incontinence as we're looking because of the innervation of the bladder in this area. When we look at lacunar strokes, these are approximately 25% of all of the ischemic strokes we see. These are strokes that are affecting the small penetrating arteries of the cerebral arteries we see. Typically, these are caused by small plaques or clots affecting the penetrating arteries. Um, Typically, what we see is it's off of the anterior cerebral artery or the middle cerebral artery. Lacunar comes from the Latin word meaning hole or lake, and it's meant to describe the cavities that happen when the brain is healing from the infarction. Typically, what we see in lacunar strokes is that 68% will have hypertension, about 30% may have diabetes, others may be elderly, smoking, or hyperlipidemia. We know between about 23 to 41% may experience neurological deterioration after the initial symptom onset. And so sometimes you may, when you arrive at the scene, you have the patient say, well, 2 days ago, I developed right arm weakness. It went away and improved. So I didn't think anything. It's come back and now it's affecting my arm and my leg. There are 5 common lacunar stroke syndromes that you may see, and so I'll just quickly review those for you. Sorry, I'm not quite sure what's happened. Sorry. Um, So when we look at sort of the various lacunar stroke syndromes we see, certainly one of the most common is the pure motor stroke. This happens when the posterior limb of the internal capsule undergoes infarction. What you see here is this stuttering course over hours or days. The patient has contralateral weakness of the face, the arm, and the leg, and slurred speech. Sometimes we also see patients who then have a pure sensory stroke. This has resulted to an infarction in the thalamus. Here we see is contralateral sensory loss of the face, upper arm, and upper extremities. It can be quite painful because they have impairment of pain, temperature, touch, position, vibration, and they can have a lot of abnormal sensory stimuli in this type of stroke. When we look at ataxic hemiparesis, this is as a result of infarction in the corona radiata. Here you see a one-sided weakness of the leg, arm and leg ataxia. Another common type of lacunar stroke is dysarthria and clumsy hand syndrome. Here you have infarction in the pons, the corona radiata, and the internal capsule. The patient presents with facial weakness, slurred speech, dysphagia, and they also have weakness of the hand, impaired manual dexterity, and ataxia. Sometimes patients may also have weakness in their arm and their leg. The final type of lacunar stroke syndromes that we see is this sensory somatic stroke. It's an infarction in the junction between the thalamus and the internal capsule. What we see here is weakness and sensory loss with no visual field deficit, aphasia, neglect, or other syndromes. When we look at posterior cerebral artery strokes, and I know Dr. Sharava will also talk about this, it is between about 5 to 10% of the strokes we see. Posterior cerebral artery strokes can be challenging to diagnose because of the variability in the symptoms that present, because it can involve the occipital lobe, the temporal lobe, the thalamus, the upper brain, and the upper brain stem and midbrain. What we see depends a lot on where and what's affected in the brain. So if it is the posterior cerebral artery stroke is primarily affecting the occipital lobe, again, we're going to see visual deficit. So we're going to have homonymous hemianopsia. We're going to have loss of vision in one quadrant. We may have visual agnosia, so patients can't recognize objects by sight. They may have cortical blindness, so bilateral occipital blindness, inability to recognize a familiar face, difficulty reading, loss of color differentiation. They may have impaired visual sensations, which they may describe as hallucinations. If we have a posterior cerebral artery stroke affecting the temporal lobe, what we may see here is we may have transcortical sensory aphasia. So you may see difficulty with aphasia, may see memory impairment. You may also see that the patient's quite agitated, angry, and quite paranoid. If it's affecting the thalamus, again, you may see one-sided sensory loss, confusion, dysarthria, decreased level of consciousness, and memory impairment. So now moving on, we'll talk about sort of some of the common assessments we'll utilize as to assess and pick up deficits in anterior cerebral artery stroke syndromes. So we'll start with last known well or stroke symptom onset. So this is a real critical piece of information, as you are aware, and it's something that really guides what treatment the patient may be eligible for. Witnessed onset of symptoms is really easy. You can confirm this time the stroke symptom onset was witnessed with the person who observed the stroke happening. However, if the stroke symptoms were not witnessed, the onset of symptoms is based on last known well. This sounds like a really simple concept, but it can be one of the hardest things to determine. For example, I live alone. If I woke up with symptoms, it would be when I went to bed if I was observed. However, no one saw me go to bed because I live alone. It would be really challenging to try and determine when I was last known well. Certainly, if the patient woke up with symptoms and the family said they were last known well when they went to bed at 10 o'clock, but got up and went to the bathroom, a key question we'd look at is, was it the patient normal when they woke up, when they went to the bathroom? Why is this so critical when we look at stroke symptom onset? Is thrombolysis has strict criteria for administration within the last known well or symptom onset less than 4.5 hours, and endovascular treatment is an option for selected patients up to 24 hours. We also know with the paramedic prompt card is stroke symptom onset less than 6 hours determines if the patient is on an acute stroke bypass protocol or goes to the closest hospital if it's outside of that 6 hours. So really key. Also recognizing that, when you are looking at these patients, family members are distraught. Their loved one has just, significantly deteriorated very quickly. They're in a bit of shock. Sometimes they need help with some clarifying questions. So looking at when did you last see the patient? When did you last talk to them? What were they doing? What were they doing last? What do they normally do at that time of the day, before or after that? Did you notice anything that indicated they were doing their normal routine? If the patient woke up with symptoms, did they get up overnight? Were they at their baseline when they got up overnight? So if they got to the bathroom, did they walk to the bathroom with no difficulty? Did you speak to them when they got up? Um, did you see them when they got up this morning? Sometimes we hear they'll say, "Oh, they got up this morning and their stroke happened, after they got up." Well, did you see them get out of bed? Did you talk to them? Were they at their normal baseline when they got up, or did they wake up and the stroke symptoms were there? Sometimes it requires some investigation and picking up cues from the scene. So, for example, the patient's daughter spoke to the patient right before dinner. She hadn't heard from her mother the next day. She found the mother on the floor at noon the following day. Dinner had been made and was on the table, but it was not eaten. So you could ascertain that, onset of symptoms was likely right after or shortly after when the daughter spoke to her because the patient had not eaten dinner. So when we move on to anterior stroke assessments, we're going to start with looking at speech assessments, and we'll looking at receptive and expressive speech. Here, what we're looking at is speech difficulties stroke patients may have are either understanding speech, so a receptive deficit or a comprehension speech deficit, difficulty expressing words, word finding difficulties, slurred speech, garbled or a speech or mute. So what we're going to start with is looking at receptive language testing. Here, what you're looking is asking them to do some really simple one-step commands to see if the patient understands. Don't mimic these for the patient, but you can repeat them to see if they understand. So you can ask the patient to point to the ceiling. Please point to the ceiling, make a fist, and close their eyes. What this will allow is if the patient has a receptive deficit, they're really not understanding what you're saying. They're not comprehending what they're doing. They may also seem confused. This is a good way to also see if they're understanding what you're doing. Because if a patient is confused, they often then can follow the simple commands, versus if the patient has a receptive language deficit, they won't be able to do those simple commands. When we look at understanding and seeing if a patient has an expressive deficit, you can show them some common objects, ask them to identify what they are, so to name them, and what does it do. So you can ask them if you have a key, a pen, a watch. Um, you can also ask the patient to say, you can't teach an old dog new tricks. What that will allow them to do is it will allow them to see is, do they have difficulty? Do they have word finding difficulties? Do they gut? Are their words jumbled as we're going? But some quick, easy techniques that you can use to really pick up on some speech deficits that you might see in your patients. When we look at movement and strength testing, what we're going to talk about is movement testing, strength testing, and pronator drift. Couple of very simple techniques that you can use, and I'm sure you're already doing, is have the patient lift their arms up in front of them and look and see if they can hold them up for about 3 to 5 seconds. You can also then apply resistance on the large muscles. Oops, sorry. Oops, I'm going the wrong way. I'll just keep there. So here you want to apply resistance on the biceps. You don't want to put it on the hands. You always want to go on the muscle. You want to see if the patient can resist the opposition of the examiner. I find it's helpful to have the patient do it themselves because it becomes very obvious if they can overcome gravity. It also becomes very obvious if, while the patient's holding their arms up, that if they have a bit of mild weakness or a drift, it's easy to pick up at that time. Again, the same with the legs. Get them to lift up their leg, apply resistance on the quadriceps, and it's really helpful then to determine motor testing. Again, what you'd want to look at is, are they able to move it through full range with maximal resistance of the examiner? Are they able to move it with full range with moderate resistance? So again, they can do the movement, but when you apply resistance, they can't overcome. Are they only able to lift it off gravity, but as soon as you apply resistance, they can't overcome? Is there some movement of the arm or the leg, but they can't do full range? So I can do this with my right arm, my left arm, sorry, my left arm, you can see I'm moving it, but I can't do full range. You automatically know that this is a 2. Is there some flicker of movement with no muscle movement, or is there no contraction to the command? A great way to test pronator drift is, again, have the patient close their eyes, lift their arms up, and as you can see here with their palms elevated, what you will do is that you will see that if there's a pronator drift, that hand will pronate over as you see. So going from here and turning over. It can differentiate very mild weakness on one side versus the other. When we look at neglect, and as we said, patients who have right hemisphere involvement can have difficulty with neglect, again, because of the spatial perceptual areas affected in the parietal lobe. So a really simple way that you can look at this as you're going, it's called the TAP test. So there's 2 ways. So one you can look at, some patients that you'll see, especially if they have pretty significant deficits, that you will see they actually have a force gaze preference to the left side. So their eyes will gaze to the opposite side of the body. If it's not a force gaze, what you want to look at is, will the pen track to the other side? If you have the patient close their eyes, can they feel the sensation on one arm or the leg when both are stimulated? Also, when we look at the shoulder tap test, is standing on the patient's left side, tapping their shoulder and calling their name. Rhonda, look over towards me. If I consistently look to the right, that's a positive test. Or it's also a positive if when I tap the shoulder, the patient doesn't quickly turn their eyes to you. They're neglecting the left side. When we look at visual disturbances or visual field cuts, patients with stroke can have a number of difficulties in this area. They can have double vision, visual field cuts, or new onset of blindness. Here you have an example of the visual pathways that we see in the brain. And just to describe what you can see is each retina has two halves. They have a left half and a right half. The halves are referred to the nasal half, so by your nose, and the temporal half by your temple. When visual impulses come in, they invert and to the opposite side of your eyes. So in this situation, what you can see is the nasal half is the right side of the body, and the temporal half is the left side of the body. But what you can see is the nasal field of vision comes in to the left side of the eye. The temporal comes in to the right side of the eye. What you can also see is then the nasal fields of vision do not cross in the left eye. But here you can see the temporal fields of vision, which come over, do cross at the level of the optic chiasm to come over to the right visual cortex. So again, you can see here, the temporal field of vision comes back, crosses over, crosses over to the left visual field. The nasal field of vision in this case comes over and doesn't cross. What that means is we have very different visual disturbances depending on where in the brain is affected. And so again, as you can see in here, if we had damage at the level of 1, we have lost the nasal and temporal field of vision in the right eye. So in this situation, we would have vision loss in the right eye. If we have damage here at the level of the optic chiasm, and not something we typically see with stroke, but sometimes we can see with pituitary masses that we may go, is what you can see is we've lost vision in both the temporal fields of vision because it's affecting both of the visual pathways that cross over. We have essentially the patient would be described as a bit of tunnel vision, so they have no peripheral vision on the side. What we see over here is really our typical patterns. 3 and 4 are the typical patterns we see in visual field loss in our patients. So what you can see here is the nasal or the temporal field of vision in the right eye comes over, crosses, is impaired before it gets to the visual field. So I've lost vision in that field of vision. Also, if we look at as we come over here, I've also lost the nasal field of vision here that comes over. So in this case, I actually have homonymous hemianopsia, and so I've lost visual field in both of my left hemifields of vision. If I have damage to the optic tracts further back in the visual in the visual fields, I can have a partial loss of vision, so only in one quadrant. And so I can have a quadratic hemianopsia. So as you can see, pie of the floor visual loss. So then how do I capture or how do I look at visual fields? A really simple way is to look at confrontation. So really having the patient look directly at you, at your eyes and your nose, testing your field of vision by showing and having the patient count how many fingers they see, looking at your upper fields of vision. How many fingers do you see? How many fingers do you see? And in your lower field of vision, how many fingers do you see? How many fingers do you see? Testing, having them close one eye, testing one eye at a time. So really, what we're looking at here is giving you some simple tips and tools to have in your toolbox to help augment your assessment of patients that you're seeing with anterior circulation when you're looking at for that patient who has arm weakness or drift, looking at speech difficulties, also looking at vision or looking at facial loss. So hopefully you found this helpful. Thank you.